let's go ahead and pick it back up. Talk about hyponatremia. This is a tough one to talk about. So what I want to do first is I just kind of want to do a high yield, like rundown, down and dirty kind of things to think about. All right. So in general, this is not always the case, but in general, hyponatremia is often a problem of too much free water. All right? In general, too much free water. Hypernatremia, however, is often a problem of too little free water in the body. And so we talk about treating, it really comes down to the time, the time of onset and how serious the signs and symptoms are, right? So when we talk about hyponatremia, for example, if the patient has mild signs and symptoms, the therapy can generally be some sort of oral therapy, right? You need to give them some oral salt solutions, right? Balanced solutions orally, right? We don't have to get too aggressive. However, this is on a continuum, and if the signs and symptoms are severe, right? And what are severe signs and symptoms in the setting of sodium imbalance? So things like severe confusion, lethargy, altered level of consciousness, right? Coma and seizures. Seizures are probably some of the most noteworthy manifestations because they stand out, right? So these kinds of things in the setting of a severe sodium imbalance are the things that indicate this is a severe problem, all right? And so in the setting of severe hyponatremia, these patients are generally going to need hypertonic saline, and that can come in two forms. The most commonly talked about form is 3% saline. And what is considered isotonic saline? Just remind me.
Isotonic, it's
0.9%, right? So isotonic saline, also known as normal saline, is 0.9%, right? It's 154 milliequivalents of sodium and 154 milliequivalents of chloride per liter, okay? So we're giving something far more concentrated, right? 3% is far more constant, something like 500 and some change milliequivalents of sodium per liter. Now, a down and dirty thing that can be done is if you don't have access to hypertonic saline, a way of increasing the sodium load in a patient would be to give sodium bicarbonate. Good, you know. Now, in all cases of correcting sodium, this should be done in concert with physician direction, right? You shouldn't be taking the initiative on your own. You should be consulting with a physician, right? Telling him, hey, this is the history, this is a physical exam, this is what I see with the sodium level. These are the signs and symptoms that I find concerning. I would like to initiate some therapy to get this patient out of dire straits, right? What do you think? Okay. Now, let's contrast that to hypernatremia, right? So, a life-threatening elevation in sodium that can cause many of these same things. Well, again, if it's mild, just oral correction, and if it's rapid onset and severe, okay, well then what? Well, some things to think about. This patient is more than likely hypertonic, right? In many cases, they're hypertonic, right? So we might want to do what? We might want to give IV fluids that are more hypotonic, right? Because that's going to cause fluid to shift back into the cells. Does that make sense? Right, so hypotonic fluids. What are some examples of hypotonic IV solutions that we have reasonably easy access to?
Of what?
What are some examples of hypotonic IV fluids that we can reasonably get a hold of, that we have reasonable access to? D5W, yes. Dextrose 5% in water. Now, D5W in its package is isotonic, right? We talked about this in pharmacology, but what happens after you administer D5W? It becomes hypotonic because the dextrose, right, gets taken up into the cell. And what does that leave us with? That leaves us with free water, right? We have lots of free water. And pure water is hypotonic, right? It doesn't have a lot of solute in it. So that is a one fluid that can be used. What else could potentially be used? It's a fairly common IV fluid. So D5W, yes. What else? Huh? Lactated ringers or Hartmann solution is isotonic.
D10.
Huh?
D10?
No, not so much D10. We talked about this. Yeah, you don't want to use sterile water. Yeah, not pure water. That's, yeah. You talked about this in pharmacology, right? This is something called half normal saline, right? Half NS, also known as 0.45% saline, right? So it's half of the 0.9, right? Well, that's going to be hypotonic, right? Make sense? So those are the two common hypotonic fluids that we would use in the setting of a severe severely hypernatremic patient, where we are correcting by giving that patient additional free water. All right. Now again, how fast are we going to administer these, and how much are we going to administer?
Titrate to the seconds we're done.
Right, and it's going to be in conjunction with with medical direction, right? I will say the general rule of thumb in sodium correction, is the following. Never change the sodium by more than 1 milliequivalent per liter per hour, okay? And the goal, okay, the general down and dirty goal should be around 0.5 milliequivalents per liter per hour, okay? So this is our never exceed, D&E, do not exceed level, and this is our optimal level. So that's pretty modest, right? So somebody has the sodium level of, say, 110 milliequivalents per liter, and they're having a seizure, right? We're not bumping their sodium up very high. We might correct it by a couple of milliequivalents, right, over the course of a couple of hours, get them out of the seizure territory, right, and then we're going to hand them over to the ICU, and they're going to do nice, slow, and steady correction, right? It doesn't take much correction. It takes, a milliequivalent or two to get them out of the dire straits typically that they're in, right? So this is pretty judicious, pretty careful and cautious sodium correction. Now I should say, what are some conditions, or I'm going to identify some conditions that cause rapid onset severe hyponatremia. So rapid onset, so this is in less than 24 hours, rapid onset severe hyponatremia. Because this is the big baddie, right? This is the one that's going to have the most profound signs and symptoms. There are some conditions that can cause this that you need to be aware of, okay? And these conditions include MDMA use. MDMA, or methylene dioxymethamphetamine. Street name is ecstasy, right? Ecstasy does a couple of things. Ecstasy is very good at acting on the kidneys. And it's very good at acting like, and actually causing the pituitary gland to release vasopressin. Remember what vasopressin is. Vasopressin is antidiuretic hormone. So if somebody takes MDMA, that MDMA will cause their kidneys to what? Hold on to water, right? So you take MDMA, it causes you to hold on to water, but it also makes you thirsty. MDMA makes you thirsty, and it elevates your body temperature, right? So your temperature elevates, you get thirsty, but you quit peeing, which means what? You start drinking, and you start retaining that water, right? Because you're thirsty, and you're not getting rid of the free water, and what happens? You start diluting out the sodium, right? This is something known as dilutional hyponatremia. All right? So MDMA, history of MDMA use, where there is excessive ingestion of water, right? That's a big problem. All right? A lot of the savvy people that use MDMA know that now and are more cautious about their use of this substance. Okay, so that's one example. Another example is something called psychogenic polydipsia. What's polydipsia? Not breathing, drinking. Right? Remember the P's? You guys probably learned the P's of diabetes, of hyperglycemia. Polyphagia, polydipsia, polyuria, right? Yeah. So polydipsia is drinking large or excessive amounts of water, right? And this is psychogenic. So this can be a psychological condition where somebody just has this psychological need to drink water, and they drink it, and they drink it, and they drink it, and they drink it, and they begin to dilute out their sodium. This occasionally can happen in people being silly, right? A few years ago, there was a radio station. I just remember where this radio station was, but this radio station had a contest. It was called P for a Wii. A Wii is apparently like a computer or like a gaming console. And they had contestants, and what they did was these contestants were made to drink large amounts of water, and the last person to urinate, so they had to hold their pee in, and the last person to urinate would win this game or this computer console, right? So during the course of this, the contestants were drinking large amounts of water. There was a female contestant. I just remember the details, but it was something like 2 gallons of water or something. It was pretty substantial. She drank a substantial amount of water and ended up collapsing on the stage where they were doing this contest, and ended up having seizures, and was then taken to the hospital and died. And she had actually died of delusional hyponatremia, right? This is sometimes referred to as water toxicity. Have you ever heard of that term? Water toxicity or water intoxication? This is it, yeah. You consume so much water that you begin diluting out the sodium in your body, right? And you have so much water in your vascular space that it becomes hypotonic, compared to the cells in your body, specifically the neurons, and what happens? Water leaves the vascular space, it goes into the brain begins to swell, you have cerebral edema, and then it shuts down. Really nasty stuff. So psychogenic polydipsia is one way. Another way of getting there. Obviously, administering hypotonic fluids to somebody. Right? This might be the result of a medication error, for example. So let's say that you are on medical surgical, and you have a patient that just came out of surgery, and the patient has an order for IV fluids, say normal saline or lactated ringers at 250 milliliters an hour, and you grab a liter of half normal saline and you don't go through your checks like you should, right? The 6 rights, and because they all look the same, right? And or maybe a half normal saline was inadvertently placed in the normal saline or lactated ringers bin. You just grab it, you hang it, and you infuse it, and then a few hours later, the patient has been given a substantial amount of half normal saline, right? And what happened? Well, that's a lot of free water, and maybe you have induced a dilutional hyponatremia by giving the patient too much hypotonic fluids. Does that make sense? That's one way to get there. So do you, when you take over care of a patient, do you look at what fluids they have up? Right, do you look at the chart and you go, okay, these are the orders, and these are the rates that the fluids need to be flowing. What do I have here, right? Oh, look at that. I've got lactated ringers, or I have half normal saline with 20 of K or 20 of potassium ordered at 150 mils an hour, and this is half normal saline without potassium that's actually been hung. Uh-oh, that's a problem, right? It's really easy to overlook things like that if we don't actually, what's in the chart, what are the orders, and what do I actually have hanging? Okay, and then the last way we can get it is actually by endurance athletes. Endurance athletes, endurance events, right? Because what do we always tell people, right? What do we tell people? Drink water, drink water, drink water, right? It's a really common thing. It's like one of the first things that happened to me when I was in the military. Well, I was born and raised in Wyoming, right? So that's way up north, relatively cold up there. And here I am, 17 years old, and I'm at Fort Benning, Georgia, home of the infantry, for basic training. Well, what's the difference between Georgia and Wyoming?
Humidity.
Oh, it's night and day, right? Heat and humidity, right? And so we did something called a forced hydration drill. Did you remember doing something, right?
Where they make you drink like
Yep.
canteens.
You had multiple canteens, right? 2, 3 canteens, and everyone would stand there, and what would happen? You'd drink a canteen, right? And then you'd hold it over your head to show you that, yep, I drank it all. And then you drink another one, and what they did is they made us drink until we started vomiting. And then so we were vomiting all over the place, and then they made us do push-ups in our vomit, of course, right? And then we drank more. Well, could you see in that kind of setting, right? Could you see if somebody's drinking large amounts of water, and then what are they doing? They're exerting themselves, right? And they're losing sodium by sweat, right? So you're losing sodium, and you're drinking lots of water. Well, that's just a perfect storm for hyponatremia to develop, right? So this can happen in endurance athletes who do not manage themselves appropriately, right? This is a tough one. So like marathon runners, it can happen. Luckily, I've never seen it happen. I do endurance mountain biking, so I'll do like 10, 12, 24-hour races on mountain bike, and that can potentially happen. Generally, we're a little more savvy, and we're not drinking, pure water. We're mixing stuff into the water to help balance it out, and we're doing balanced solutions and things like that. But it can happen, right? It can definitely happen.
So you can actually prevent that by putting like electrolytes in your water?
Yeah. A lot of us will put electrolytes in our water, or we'll drink electrolyte solutions. Typically, like things like Gatorade, the problem with Gatorade is like it's a lot of sugar, it's really hypertonic. So you might like dilute the Gatorade, like half strength Gatorade and things like that. Some people will actually take tablets like different electrolyte tablets, and they'll do so many tablets every 15, 30, 45. You kind of figure out what works for you. Everybody has something a little different. There are little gels or little gummies that have sodium and potassium in them that people can take as well. So you just have to be careful. And drinking significant amounts of pure water when you're sweating a lot really can lead to.
That happened to me like 2 weeks ago.
Yeah, I can
I
think
thought
it
I
happen.
was like gonna pass out.
You feel horrible, huh?
Yeah, it was like the worst. I literally thought I was dying.
Yeah, you could have had some hyponatremia. Your potassium could have been low as well. Yeah. Generally people will start getting heat cramps, right, before they get super hyponatremic. But again, if we're dealing with a type A athlete, right, they may be able to power on through some of the signs and symptoms that would concern us, right? Because they're like, oh, I'm always uncomfortable, I'm going to power through this, and then they get themselves in a bind. Or someone like me, who maybe I'm from Wyoming, I'm used to cool, dry weather, and now I'm in a super warm, super humid environment, right? And just the different environment, I don't know how to manage myself in that particular environment. So you can run into that as well. But these are some causes of kind of this rapid onset severe hyponatremia that can develop. Does that kind of make sense there? Okay, so that was down and dirty, okay? That's down and dirty hyponatremia. So now what we need to do is I want to talk about hyponatremia in a little more of a formal context. So this is like out in the field, kind of down and dirty guidelines, rules of thumb. But now you guys are in the hospital, and you're going to spend half your time in the hospital, in the clinical environment, right? You have you're going to do, well, almost half your time. You're going to do 2 rotations in the hospital. So 6 credits, 3 credit classes, 2 3-credit classes, and then you're going to do 2 rotations on the ambulance, or 6 credits. And then your final 3 credits is your internship, which will be on the ambulance. So you're going to spend a few hundred hours in the hospital at least. So you're going to run into some of this. It's really common. Sodium imbalance is really common, and particularly in the ICU and on the medical surgical floor. Okay, so let's start here. Let's start here with hyponatremia. So again, hyponatremia is just a sodium level of less than 135 milliequivalents per liter. You guys okay with that?
Right.
All right, so it's low sodium. It's low serum sodium. Okay. So our patient has hyponatremia. We've identified that they have hyponatremia. What do we need to do? Well, we need to get a good history and physical exam, and we need to look at their signs and symptoms. Right? How urgently do I need to treat this? Now, in addition to that, there are some other things. We need to figure out what kind of hyponatremia we're dealing with, right? And the first thing that we can do to point us in the right direction is go back to the serum osmolality. Remember we talked about the serum osmolality earlier today? So what we need to do is we need to look at the serum osmolality.
That's the overall, right?
Yes.
Amount of.
Yes, the serum osmolality. And there are 2 serum osmolalities that we're going to need to get. Okay? The first serum osmolality is measured. All right? This is actual measured serum osmolality that comes from the lab. All right? So we're going to get that. The second is we're going to need to calculate the serum osmolality. Now, in a normal situation, what gets measured at the lab and what I calculate should be what? Should be the same, right? If there's a difference, if there's a substantial difference between what's measured and what I calculate, there's something going on, okay? So, hyponatremia happens, we get a good H&P, look at the signs and symptoms, and we try to categorize this as a mild to moderate to severe manifestation, all right? At the same time, we need to look at the patient's osmolality. And just remind me, what is the normal osmolality for a patient?
275 to 295.
Say it again?
275 to 295.
275 to 295 what? Milliosmoles per kilogram. All right, good. So that's the normal range. All right, so we're going to first get measured and then calculated. All right, so how do I calculate the serum osmolality for the patient? I'm going to give you guys a formula. All right, and the formula is 2 times the sodium, whatever the sodium value is, plus the glucose divided by 18 plus the blood urea nitrogen divided by 2.8. All right? And there are actually really good online calculators that'll do this for you. Right?
So it's 2 times the sodium.
2 times the sodium. Mm-hmm.
What's the glucose?
Plus glucose divided by 18, plus blood urea nitrogen divided by 2.8. BUN, right? Blood urea nitrogen, yeah. Okay, does that kind of make sense? All right, so if the difference between the measured and the calculated, if there's a large difference, all right, if there is a large difference between measured and calculated, something is causing that difference. There is some hidden substance that we have not measured yet that is causing that difference. Does that make sense? All right? Because the measured and the calculated should be about the same. If there's a large difference, the first thing I want you guys to think about is toxic alcohol ingestion. That's going to be one of the most common causes. Toxic alcohols. Toxic alcohols, right? And these include methanol and ethylene glycol. We mentioned these earlier in pharmacology, right? When we talked about antidotes to toxic alcohol poisoning. We talked about fomepizole. All right. You guys okay with that? So again, low sodium, H&P with signs and symptoms. Find out what the serum osmolality is, what's measured, what's calculated, and then subtract calculated from measured. If the difference is large,
What would be considered a large difference?
it's going to be your kind of your clinical call, right? Say 5 or 10, something like that. You know, if it's substantial, there's a substantial difference where you go, oh boy, that's pretty substantial. What's going on here? I want you to think about toxic alcohol overdose or ingestion. Does that kind of make sense? You guys okay there? All right.
We see a lot of drunks in the ER.
Huh?
Yeah, because we see a lot of drunks in the ER.
Right. And maybe they got into some homebrewed stuff, whether it was adulterated with methanol or
Drinking after shit.
yeah, things can happen. You guys good with that?
Yes.
Okay, the next thing that I want you to think about is the glucose. All right? Is the glucose. I want you to do a glucose correction. A glucose correction. So we need to correct the sodium for the glucose. And the rule of thumb is for every 100 milligrams per deciliter beyond a BGL, blood glucose level of 100 milligrams per deciliter, okay, you're going to add 1.6 milliequivalents per liter to the measured sodium. All right? So for every 100 milligrams per deciliter, I keep mixing that up. I keep saying deciliter. It's decaliter. It's tenth of a liter. For every 100 milligrams per deciliter of glucose beyond 100 milligrams per deciliter, add 1.6 to the sodium. I'm going to work through an example to demonstrate how this works. All right? So let's say that we're working our patient up, and our patient has a serum sodium of 130 milliequivalents per liter. So what would you say at face value? That's hyponatremia, right? This patient has hyponatremia at face value, right? So what do we need to do? Get a good history and physical and get signs and symptoms on the patient. And at the same time, look at their serum osmolality. So let's say that their measured and their calculated serum osmolality is more or less the same. There's not a huge difference. So then we're going to move down and we're going to look at this patient's glucose. And let's say that this patient is in DKA and they have a glucose of 600 milligrams per deciliter. You guys okay with that? Awesome. So for the first 100 doesn't count, right? So how many hundreds do I have above that first 100? 5. So what I'm going to do is I'm going to take 5 and I'm going to multiply that by what? 1.6. Do you guys see where I got 5 from? Because it is 500 beyond 100, right? So what is 5 multiplied by 1.6? That is 8. And then what I'm going to do is I'm going to take that 8 and I'm going to add it to the original sodium. So what is my corrected sodium? So the corrected sodium in this particular patient's case is 138 milliequivalents per liter. So this patient does not have an actual hyponatremia, right?
And this is after you've assessed the patient, got the history, you did your measured and calculated, and it's still not adding up, right?
The measured and calculated, you didn't see a whole lot going on here.
Right.
So toxic alcohols, you're like, that's not likely. Then you move down, you look at, okay, well, what's a patient's blood sugar, right? Now, I will tell you that in this case, is the patient's, in the case of this DKA patient, is their serum osmolality going to be high or low? It's going to be really high, right? Because they've got a lot of sugar in there, right? But the calculated should be high as well, right? Because the glucose is 600, and remember, we take glucose into consideration. And more than likely, because they're dehydrated from DKA, is their BUN going to be high or low? Probably going to be high, right? Because they're dehydrated, their kidneys are probably have some degree of dysfunction, right? So the glucose and the BUN are going to be high, so our calculated should be high as well as measured. They should both be pretty high, right? So in this case, we move on and we go, oh, look at this. I'm not as concerned about this, right? It's a false low reading. So you see how labs can be really misleading if we take them at face value? And again, that's why I keep emphasizing these exceptions and a history physical. Okay. So let's say that in this particular patient, that it's not a toxic alcohol problem and it's not a blood sugar problem. Let's say that their blood sugar is okay, or maybe it's just a little high, and they legitimately have hyponatremia. You guys okay with that? So then what we need to ask ourselves next is, what kind of hyponatremia do they have? Right? Do they have something known as a hypertonic hyponatremia? Guess what? I just took you guys through how to find a hypertonic hyponatremia. The two most common types of hypertonic hyponatremia are going to be toxic alcohols and high blood sugar, DKA. Well, I just show you how we can account for those, right? So that's hypertonic. What does that mean? That means that there is some other substance floating around in the bloodstream, right, that is taking the place of some of the sodium. It is exerting osmotic effects, and we haven't measured it yet, right? It's a toxic alcohol, or it's high blood sugar. You guys okay with that? All right. So we've dealt with hypertonic. The next one is what's known as isotonic. Okay. And this is another false one, in a sense. And the most common cause of an isotonic are going to be excessive fat levels and protein levels in the blood. All right. So we're going to want to look at the patient's lipid profile, right? And if they have, let's say that their lipids are like 2,000, okay, that's probably what's causing their sodium to show up low, right? So we've ruled out hypertonic and we've ruled out isotonic. What does that leave us with? That leaves us with hypotonic. All right. So we're going to move down here to hypotonic. So what I'm drawing for you is, hopefully you can see, this is kind of a decision tree. This is kind of an algorithm to help you make decisions. Okay, well, hypotonic. So if the measured and calculated serum osmolality, so if measured and calculated osmolality are low, if they are low, that strongly suggests hypotonic hyponatremia. Okay? You guys okay with that? All right, so let's talk about hypotonic. So when it comes to hypotonic hyponatremia, we need to identify the cause of that. And the cause is going to be related to the patient's fluid volume status. Okay? Could the patient be hypervolemic? That is, they have too much fluid on board. Can that cause hyponatremia if I have too much water?
Right, because it becomes
Dilutes, right? You guys okay with that?
hypotonic, right? Which draws the sodium.
Yeah. So one cause of hypotonic hyponatremia is what's known as hypervolemic. Right? I've got too much fluid on board. Too much fluid on board. What kinds of patients, again, the history and physical, what kind of history is going to suggest that their sodium imbalance is the result of hypervolemia?
Renal failure.
Say that again?
Renal failure.
Renal failure with water retention. Renal failure with water retention, they're retaining water. Absolutely. What else?
Congestive heart failure?
Absolutely. Congestive heart failure patient. If this looks like the Pillsbury Doughboy, right? This is someone who's all swelled up. They've got pitting edema. They've got wet lung sounds, right? They look like they are in congestive heart failure and their sodium is low. We want to be thinking hypervolemic. Does that make sense? It's a volume problem. So congestive heart failure. Good. Congestive heart failure. And the general treatment in these cases is going to be getting rid of the water, right? How do we do that? Well, we diurese them.
So it would be a diuretic that doesn't affect the sodium level.
Possibly, yeah. Well, that's potassium sparing,
Potassium.
yeah. We diurese them, right? We diurese them. Does that make sense? All right.
Would you also see it in hepatic failure?
Huh?
Would you see it in hepatic failure?
You can, because hepatic failure often is associated with renal failure and hepatorenal syndrome, but it's really the kidney. Yeah. So CHF and renal failure are your two big ones. Diurese them, and obviously with renal failure, if their kidneys just aren't working at all, they may even need dialysis. Good. Does that make sense? Okay, cool. So the next one is something called, actually I will skip that one for a second and I'll move on over to this one here. And this is called hypovolemic. So this means that they have what? They have low blood volume, right? So what kinds of things can cause hypovolemic hyponatremia? So their fluid status is low and their sodium status is low.
Septic shock.
Good. Sepsis. Septic shock, right? So let me just try to keep it looking the same here. So if this patient has fever, this patient has sepsis, tachycardia, diuretics, right? They're on excessive diuretic therapy. That's going to do what? That's going to cause them to lose both sodium and water, right? So fever, sepsis, persistent tachycardia, excessive diuretic use, those are all things that suggest that this is hypovolemic. How do we treat them if it is hypovolemic? Give them fluid. Good. Yeah, give them fluid. Right, this is someone who probably would benefit from normal saline, right? So you're going to give them a little bit of sodium and fluid, right? Does that make sense? All right. And then the last one that I want to talk about is euvolemic. Right, is euvolemic. All right, is euvolemic. All right, that means that their fluid volume status is what? Normal, right? Normal. And the things that I want you to think about for euvolemic hyponatremia include rats. Just think of rats. R-A-T-S, rats. All right? There is a disorder, and we'll talk about it in more detail in other blocks, but I just want you to kind of know of it. And it is renal tubular acidosis, or RTA, renal tubular acidosis. It's a condition, and we'll talk about that in more detail when we talk about the urinary system. So renal tubular acidosis. Okay, that's the R. The A is Addison's disease, specifically Addison's crisis. Does anyone know what Addison's disease is? And we'll talk about it in greater detail in endocrinology. So Addison's disease is where part of your adrenal gland fails. So you know there are two major parts of the adrenal gland, right? There's the adrenal cortex and the adrenal medulla. Now the medulla of the adrenal gland, that's the middle part, right? The medulla secretes epinephrine, norepinephrine. That's part of the sympathetic nervous system, right? But the cortex, the outer part of the adrenal gland, secretes what are known as corticosteroids. That's why we call them corticosteroids, right? So substances that are similar to what? We give them sometimes to respiratory patients primarily. Solumedrol or methylprednisolone, yeah. Decadron or dexamethasone, right? Yeah. Solucortef or hydrocortisone, right? These are all examples of modified corticosteroids, right? So the adrenal cortex secretes something called cortisol, and it produces two categories of steroids known as the glucocorticoids and the mineralocorticoids. And the glucocorticoids help regulate blood sugar, and the mineralocorticoids help regulate electrolytes. So someone with Addison's disease has an adrenal gland that is no longer secreting cortisol, which means the patient's no longer making gluco and mineralocorticoids, and they can no longer regulate their electrolytes effectively, right? So things like sodium, they end up losing sodium. Does that make sense? You guys okay with that there? That's kind of the gist of Addison's disease, and we'll talk about that in more detail. The T is thyroid problems. Thyroid dysfunction. Typically, the type of thyroid dysfunction that tends to cause euvolemic hyponatremia is hyperthyroidism, not hypo. Hyperthyroidism, right? Graves' disease, or if the life-threatening manifestation of that is something called thyroid storm or thyrotoxicosis. And then the very last thing that you want to think about after you ruled in or out these other causes is something called SIADH, Syndrome of Inappropriate Antidiuretic Hormone. So remember earlier we talked about diabetes insipidus. It said that diabetes insipidus is typically a problem of, if it involves a pituitary gland, it's typically a problem of what? Not enough vasopressin, right? Well, SIADH is a problem of too much vasopressin. So what happens is if you have too much vasopressin, your kidneys are not getting rid of free water, and the sodium gets diluted out. And that creates a dilutional hyponatremia. So your patient's not losing water, right? So their volume status may not change very much. You guys okay with that? All right, so that is hyponatremia in a nutshell, and this is kind of a way to approach hyponatremia when you have labs. When you don't have labs, or when you don't have the ability to get a really good assessment because the patient's seizing and doing the kick and chicken and they're critical, remember the down and dirty that we talked about a little earlier, right? So you've got kind of that down and dirty we talked about earlier, And then we've got this little more nuanced approach for when we've gotten over the emergency, or the patient is just not having substantial signs and symptoms. And I guarantee you, if you go through this and you do these calculations, and then you start talking to the physician that's caring for that patient, you're going to be an absolute boss, right, in that physician's eyes, because a lot of people don't understand this, they don't do this. You approach that physician, right, you're like, well, this patient has a hyponatremia, but I saw that the patient's glucose is 800, and I did a glucose correction, and the corrected sodium is actually normal, so I think that the hyponatremia is actually just an artifact from the patient's glucose. What do you think, doc? And the docs will be like, dang, yeah, right? And then what's going to happen is, right, the following day, that pulmonologist physician is circling, or that pulmonologist patient is circling the drain, and that doc, and you're like, hey doc, do you mind if I intubate the patient? And that doc's going to remember, oh wait, this is a guy who really knows about critical care. Hell yeah, I'm going to let you intubate my patient. Get in here and do it. And that's how it happens. You build these relationships, and you're able to, they treat you nice, or they'll pull you in and be like, hey, we're going to do this procedure. Do you want to come and help me, right? It really does help you out. And it really helps you in practice, right? Because you guys know, right? The people in the emergency room, people in ICU, they kind of know that the EMTs and paramedics, right? And they're like, oh, right, this person has this kind of reputation, right? And that reputation can be very helpful when it comes to dealing with different providers. As you guys know, some providers can be more or less difficult to deal with. Much easier to deal with people when you actually know what's going on and you have a good foundation to make arguments on. And it just helps you with good clinical practice as well. Okay, you guys good with that? Okay, I think that's all I want to do today. Let's just stop there. I'm not even going to touch acid base because you guys have plenty of stuff that you need to study and think about over the weekend.